Chris Boodram. He's a senior policy analyst with HIV/AIDS Policy Coordination and Program Division at Public Health Agency of Canada, where he provides policy advice on the federal role in addressing HIV among gay, bi, two-spirit, and other men who have sex with men. But Chris is going to present today mental wellness of gay men as a determinant of vulnerability to and resilience against HIV/AIDS, a review of Canadian evidence.
What I'm going to be doing is presenting some preliminary findings of a review of the Canadian evidence that we've done on gay men, bisexual men, two-spirit men, and other men who have sex with men's mental wellness as it relates to social determinants of health and HIV vulnerability. But before I get into that substance, I'd just like to contextualize the work that we've done within some of the broader knowledge translation work that the Public Health Agency does on HIV vulnerability among the populations that are especially at risk for HIV. As I said, this is a preliminary survey of evidence, and so I'm very interested in the discussion that follows. And if anybody has feedback on additional resources that we should be looking at or additional information we should be taking into consideration, or the way that these findings have been presented, then I'd be very interested in hearing it, and my contact information will be at the end of the presentation. So, contextualizing, federal initiative, it's what guides the federal response to HIV and AIDS, basically. There's a number of things that we do as a federal government in there, but it includes program and policy interventions, and so the funding streams that a number of the programs that many of you represent get funding from are included under the federal initiative. And also there's a strong knowledge development and knowledge translation function that we try to fulfill there. And so a big part of that is the series of status reports that the Public Health Agency is doing on basically the state of HIV among the 8 key populations that we've identified as being especially vulnerable to HIV and AIDS. And so in there you'll see gay, two-spirit, bisexual, and other men who have sex with men as one of the 8. The status reports, as I said, are part of what we're doing in terms of knowledge translation. And, of course, the purpose of knowledge translation is to try and enable all of the different bits of research that people are doing to really inform policy and program development in a concrete sort of way. And so in doing this and other pieces of work on knowledge translation, we're hoping that it's going to end up informing our own priority setting as the Public Health Agency and the Government of Canada, including with regard to how funding programs work. We're hoping that they're going to build community capacity to understand how HIV is working in communities and to better our collective response to it, help community organizations in developing and improving programming, identify areas that need further research, and generate discussion among national stakeholders that are engaged in the response to HIV and AIDS on what we need to do going forward. So far in terms of this series of status reports, we published one on people from countries where HIV and AIDS is endemic. That was published in 2009. There's another one on HIV and AIDS among Aboriginal peoples that is just in the final stages of approvals and should be released literally any day now, actually. And we're working on a number of others, including one of the 2 that I'm responsible for, which is gay, bi, two-spirit, and other men who have sex with men. Now, before I go further on this, I just want to acknowledge that quite a lot of you in this room will probably have heard about this series of status reports before, including the one on gay, bi, two-spirit, and other men who have sex with men. I know that it's been presented at this series of conferences previously, and we have been working on it since 2006. The original date that we were hoping to be able to publish it was 2008, but we've had a number of challenges, mostly personnel and staffing challenges that have made that progress a lot slower than we really wanted it. And so as of September of this year, I'm the new guy on the file, and I intend to keep it moving forward. And we're hoping that we're going to have a good draft of the entire report ready by March of next year, and hopefully publication within fiscal 2011-2012. So just wanted to give that bit of context. So in terms of the scope and methodology of the reports, we've developed a standardized outline for each of the 8 reports and a fairly rigorous, we think, methodology in terms of how we pull together information from peer-reviewed gray literature, how we do our keyword searches, and how we work with our expert working groups to pull together the information that's in there. I'll just highlight the list of chapters here that it will give the kinds of information that's actually going to be contained in these reports as when they're done. And chapter 4 is going to be broken down according to the 12 standard determinants of health that we've already referred to today, as well as sections on unique determinants of health for whichever population that we're talking about. And so, as we've been talking about today, there will probably be a few that are specifically relevant to gay, bi, two-spirit, and other men who have sex with men. So before I plunge into the results, I just wanted to highlight at a really high level why we're still talking about HIV/AIDS among our communities. I will also highlight that I've come up with my own awkward acronym to reflect the population that I'm mandated to work on. So that's gay, bi, two-spirit, and other men who have sex with men. So a very brief epidemiological overview based on the 2008 Canadian estimates that the Public Health Agency put out. As we can see, the MSM exposure category is still the single largest exposure category for new infections, and people exposed through at the MSM category make up about half those that are currently living with HIV in Canada. New infections continue to occur. The rate of new infections is not going down. And we estimate that about 19% of MSM, or people infected through the MSM exposure category, don't actually know that they've been infected. So all of that just to quickly highlight that this is still a really key issue for our communities in terms of addressing gay men's wellness. So I'm going to switch gears and present some of the specific findings of the preliminary work that we've done. What we've done is initial literature search of the peer-reviewed literature and the gray literature just to see what there is out there in terms of Canadian evidence specifically on mental wellness among gay, bi, two-spirit, and other MSM as it relates to vulnerability to and resilience against HIV. So this is a very high-level summary of what we know from the Canadian evidence. So first of all, I'll just say that most of this is not going to surprise anybody in this room. We've already referred to quite a bit of it today, and but I think that there is value to going through the exercise, going through the review, pulling together what is known about this population in the Canadian context and outlining it. And so that's the enterprise that we're going through here. The other thing that I would like to say is that just to contextualize this a little bit, we know that the health profession has gone through quite an evolution over the last 40 years or so. 40 years ago, homosexuality was regarded as a mental illness, and today we're talking about studying the effects of homophobia and heterosexism on our health as a legitimate area of study, if under-researched area of study. So really quickly on the findings, generally we find that, I will also mention that one significant gap that we came across in doing this is that there was nothing published or in gray literature about MSM, men who have sex with men who don't identify as gay, bi, or two-spirit. And so it was really interesting to hear Terry's presentation earlier today of a fairly substantial sample of information that he was able to collect from people identifying as MSM. So that's really exciting, and we'll be looking at how to incorporate that in this review. But I hadn't seen anything on MSM, and there was very little also on two-spirit. So those are clear gaps. Thank you. So we saw a higher incidence of depression, anxiety, bipolar, other mental disorders among gay, bi, and two-spirit men. Some of the literature simply reported it. Other pieces of the literature actually tried to correlate it with internalized homophobia and negative attitudes towards one's sexuality. Some studies that we looked at showed higher rates of alcohol and drug use. Others didn't actually find any difference between rates among gay, bi, two-spirit, and heterosexual people, so a bit of an unclear finding there. A much clearer finding was higher rates of suicidal ideation and suicide attempts. One meta-analysis that we looked at averaged out the rate or the increased risk as being about 6 times that of the risk of the heterosexual population. And another finding that is really important to illustrate is that gay, bi, and two-spirit youth were especially at risk of depression, anxiety, low self-esteem, isolation, hopelessness. And a number of studies that we looked at correlated that with experiences of harassment and violence. Another thing about youth is that they were at higher risk of suicidal ideation and suicide attempts, and some studies suggested that that risk was up to 13 times the risk of their heterosexual peers. So, why is this? Why do we have poorer mental health outcomes as a population? Here's a bit about what the literature is saying about this. And again, none of this is really going to be a shocker, I don't think. It's interesting to note that not all of the literature looked at this. Some of it simply did questionnaire-style surveys to highlight a correlation between a sexual minority status and poorer mental health outcomes. There were, encouragingly, a number of more qualitative studies, usually done through a focus group methodology, that tried to explore causality in a more thorough fashion. But overwhelmingly, homophobia and heterosexism emerged as broad determining factors in mental wellness and also overall wellness, it should be said. At the individual and interpersonal level, if you've experienced harassment, bullying, or bashing, that was correlated with the poorer mental health outcomes in a number of studies. And looking at the systemic level, heterosexism tended to impact people's feelings of safety, their ability to come out, their ability to access support, and their ability to access appropriate healthcare services. And another important finding was that, and we talked, this harkens back to one of the presentations this morning, men who were facing multiple marginalizations, and so two-spirited men, men from racialized and ethnocultural minorities, seemed to be especially at risk. There was a cumulative effect in terms of poorer mental health outcomes. And so in the context of the discussion on intersectionality, that was a really interesting finding that I think bears more investigation. So how does all of this affect vulnerability and resilience to HIV? It is very well documented that at an individual level among gay, bi, and two-spirit men, stress, anxiety, low self-esteem, feelings of hopelessness, depression are strong predictors of unprotected anal intercourse with partners of unknown HIV status, which of course is one of the major risk behaviors for our communities. Something that is less well delineated is the interpersonal and social and structural factors that influence mental wellness and HIV vulnerability at a population level. In both peer-reviewed literature and gray literature, quite a few people are pointing out that if when you focus on the individual level, individual internalized homophobia and its impact on mental wellness, you tend to come up with individual interventions and individual solutions, which misses a big piece of the picture. We know that new infection rates are not decreasing among our communities, and that MSM is still the single biggest transmission category. And so we've had quite a history of individualized interventions and solutions and pieces of research. Maybe there's something missing there. So that's actually a fairly good segue into a summary of the recommendations in the literature. Quite a number of the literature contained recommendations beyond the standard, well, we need to do more research on this. Generally speaking, people were saying that we need to move beyond documenting internalized homophobia and its effect on mental wellness and vulnerability to really looking more closely at the interpersonal and the systemic levels of homophobia and heterosexism and how those affect both mental wellness specifically and wellness generally at a more structural level. Taking a closer look at the ways in which homophobia and heterosexism play out in people's actual lives was outlined as something that would be really useful in terms of getting a real sense of how interpersonally and structurally some of the specific mental health and HIV vulnerability links may exist in terms of life passage kinds of things like coming out, starting to date, establishing social networks, etc. The literature also talked about interventions, and so like research, it said that interventions need to broaden. Specifically, the trend seems to be moving beyond a specific HIV focus on gay men's health towards a more holistic focus on wellness, generally speaking, including mental wellness. And a number of articles suggested specifically that this actually is going to help better address HIV risk factors by doing it at a more systemic level. A number of articles also addressed the structural level and pointed out that the invisibility of gay, bi, and two-spirit men in health policy development is a significant factor. And some of these articles urged a consideration of sexual orientation's impact on determinants of health. A few of them even suggested that sexual orientation itself is a really key determinant of health that we need to take a look at the structural level. And in terms of research gaps, I've already talked about MSM. There wasn't a whole lot in terms of two-spirit men and mental health, although there was a bit more on racialized and ethnocultural minority men, although probably not as much as there should be. So this slide is really just my own effort to just put together a little bit of a map of how all of these factors pull together to affect mental wellness and thus HIV vulnerability. So at the top of it, we see heterosexism, and examples that are given there are systemic bias and invisibility. At a more interpersonal level, we have homophobia, and so that manifests through a number of ways, including exclusion, discrimination, harassment, violence. Both of them at the structural and the interpersonal level seem to have an effect on key determinants of health. And so there are 12 sort of standard key determinants. I've pulled out 6 that I think are especially relevant to mental wellness, although certainly that list is debatable. That's something we could discuss. So the conclusion of it all basically is that heterosexism and homophobia, mediated by some key determinants of health, do seem to have a significant effect on mental wellness and therefore vulnerability to HIV for gay, bi, and two-spirit men. And I suspect that it's fair to extrapolate a more generalized effect on wellness as well. So that's it. I hope this is a useful way to think about the links between all of these factors. Any feedback on the findings, on additional things that we should be looking at would be extremely welcome. You've got my contact information there, as well as the contact information of my manager. I'm really happy to have been here and to be able to present this. I think this is a fantastic conference, and the presentations that we've heard thus far are really helping me to think through some of the information that I've been looking at. So I look forward to the rest of the conference and to a good discussion. Thank you.